Hi, this is Elliot Fishman, and welcome to part 3 of our talk on cystic pancreatic lesions, detection, diagnosis, and management. And we left off last time where we said we were going to focus on serous cystadenomas. This is one of my favorite lesions. Serous cystadenomas are quite common, and they're benign tumors. They mainly affect women in their 50s and 60s, so it's a bit older than the MCNs, which are in their 40s and 50s, and so they're often called grandma-like tumors. There typically are 3 different categories: microcystic, macrocystic, and a mixed pattern, as well as a honeycomb pattern, which is pretty rare. One of the interesting things about these lesions, they don't communicate with the main pancreatic duct. People tend to make that mean that they don't obstruct the pancreatic duct. And people say, well, you see a dilated pancreatic duct, it's not a serous cystadenoma. But as I'll show you examples, just because of its mass effect, you can see ductal dilatation, particularly with downstream ductal atrophy. They account for about 20% of primary cystic pancreatic neoplasms. Again, it all depends how many you think are IPMNs, because if you call every tiny IPMN a cystic lesion, then obviously everything else is going to be even a lower percentage. They're benign, and they're classically described as a multiloculated cystic mass with a central stellate scar with calcifications on CT. That's kind of the that's the one that's in every textbook everybody thinks about. Again, we mentioned before it's more common in women. So it's women 50s and 60s. Usually it's incidentally discovered, but if they're large enough, they do cause symptoms. So they're not always going to be asymptomatic incidental findings. And they can present with abdominal pain, abdominal mass, and depending where they're located, even with jaundice. So we talk about this classic appearance. We talk about thin septations and multiple cysts. We talk about a central scar with coarse calcification. We also mentioned, of course, that how things look will vary. We talk about the oligocystic type, which is basically a cystic lesion, which can look both in location, size, and age like an MCN. The thing about serous cystadenomas, they contain glycogen but no mucin, so when you sample them, you can make that decision. And again, more common in women. So if we talk about 3 types, and I kind of like this 3-type approach: polycystic, honeycomb, which is like that classic one we look at, better seen venous, and the oligocystic. So polycystic, most common, roughly 70% of cases. The cysts tend to measure around 2 centimeters or so. That central scar of calcification, not uncommon. But with serous cystadenomas, there can be a range of calcifications that are present. In the honeycomb pattern, we talk about multiple small cysts, too numerous to count. They're typically under a centimeter in size, and it's just hard to separate them because there are so many cysts that are present. And of course, the oligocystic is the least common. It's usually one main cyst or one main cyst with a septation. One of the challenges, again, particularly when they're not overly large, is based on patient age, female predominance, location. They can very much be confused and hard to separate from MCN, so that can be challenging. So let's share some of them. Here are the classic MCNs: large cystic pancreatic lesion, coarse calcification, large septations. I do believe, in my experience, has been that when you look for septations in serous cystadenomas, as well as truthfully almost any lesion, the septations are better seen in venous face imaging. I also think with serous cystadenomas, and I'll show you examples, the multiple tiny cysts are often easier to see on venous than arterial face imaging. You can see very nicely in this case the large cysts, the septations, the coarse calcification both centrally as well as distributed, including periphery of the lesion. And again, the more you look, here we're going to venous phase, cystic lesions a bit better defined, large lesion, no dilated pancreatic duct, no dilated common duct. Here it is from the sagittal view. Again, just look at those lobulations, look at the calcifications, just a really nice appearance. Another example, here's one that arises in the pancreatic head. Large cystic lesion, large septations, faint calcifications. The septations here are well defined for the most part, and the cystic lesions are large, right? They're 2 to 4 centimeters or 5 centimeters. So this is not a honeycomb appearance. Yes, you can say there are multiple cysts, but when we talk about honeycomb, the cysts are under 1 centimeter in size. Just a very nice example. You can see in this case there's a little prominence of the common duct. One way of recognizing this and saying it's not an IPMN is the fact that you do see the septations like this. You do see some of the wall definition. If you worried this was an IPMN, it would be malignant, right, with septations and being this large. But IPMNs never get this large. We have found with cinematic rendering that you can see the septations, in this case a little bit better. Another patient, large pancreatic mass, coarse calcifications. I got to be thinking that this is a serous cystadenoma. There's no dilated common or pancreatic duct present. Again, I could think of other things. I could think about a SPED tumor. They can have coarse calcifications, can be cystic and large. This is not the look of an MCN. It's not the look of a pseudocyst. It's not the look of a neuroendocrine tumor. But very coarse calcifications and cystic components, serous cystadenoma. And you can see how large it is. Now, we talk about that serous cystadenomas are benign. They don't invade in the sense of a malignancy. But you can see in this case, there's scalloping along the portal vein and SMV. So one of the things with serous cystadenomas, I mentioned before, they can obstruct the pancreatic duct and cause distal glandular atrophy, but they also can push on the portal vein and SMV and kind of give a scalloped appearance, which makes you always worry about malignancy, but it's not going to be malignancy. And here it is on MIP imaging, very nicely showing you those coarse calcifications. And another case, you can see the vessels are draping over the lesion. Mass effect with draping, not uncommon with serous cystadenomas, but that coarse central calcification gives things away. Just a really nice example. And again, you can see because of compression on the portal vein and SMV, there are lots of collaterals on the left flank of the patient's tumor. Again, the coarse calcifications really nicely shown on MIP imaging. Remember, MIP imaging is a projection technique, so it projects everything forward, and so it really makes it like a cluster of calcifications, while in fact, if you looked at the individual slices, they're distributed throughout multiple parts of the patient's lesion. And again, look at this example, large cystic components, calcification centrally as well as peripherally. I think one thing, and one of the reasons I like to show a lot of cases, is because when you see a bunch of these, you begin to get comfortable in recognizing them. You're not going to be afraid, oh, I'm overcalling or I'm undercalling. Another example, here's one from the tail of the pancreas, large septations, and the lesion is basically hanging off the undersurface of the gland. Again, what else could this be? It's not an IPMN. It doesn't look like an MCN. There's too much solid and cystic component and septations. You know, it's really hard to figure out what else this can be. It's not a pseudocyst. It's not going to be a neuroendocrine tumor. This is a serous cystadenoma. So one thing also to comment on is that serous cystadenomas can at times look relatively aggressive. Here it is when I narrow the window on the venous phase imaging. Remember, I mentioned a few moments ago that the septations as well as the cystic components may be better seen on the venous than arterial phase imaging. Here's another lesion over 12 centimeters in the head of the pancreas, but again with serous cystadenoma, you don't see common duct dilatation. Again, it's pushing on the stomach, multiple septations, and we talk about how it encases and drapes vessels. So you can see vessels are often stretched around the edge, particularly true for GDA and hepatic artery, as well as for portal vein and SMV. So one of the things you do see with serous cystadenoma is this draping phenomena. And here you can see very nicely the patient's GDA is draped by the mass. Now, if you say vessel distortion, you're always worried about malignancy. But with malignancy, there's vessel invasion and irregularity, With serous cystadenoma, the vessels are stretched. It's really a stretching process, and you have this draping sign. And here it is, again, some other images on venous phase. Again, you can see the multiple septations in the lesion. So it's not just the bigger cystic lesions, but multiple tiny under 1 centimeter septations. Again, very nicely shown here with the stretching of the patient's portal vein and SMV. So again, a really nice example, but no intrahepatic duct dilatation. This case also was one of those that was clinically symptomatic. The patient had some abdominal pain, and that's because the cystic lesion is compressing on the stomach, which can give gastric outlet obstruction or just general feeling of malaise. And on clinical exam, the internist palpated this mass, was concerned for malignancy. Fortunately for this patient, this was a serous cystadenoma. She did need surgery, but this was not a malignancy. And again, the stretching of the vessels cannot be overemphasized. So I've shown you that. I've shown you the cystic components of the lesion to really, again, get you familiar with the spectrum of serous cystadenoma. In this article by Wang, Discrimination of Serous Cystadenoma from MCN, made the point that pancreatic cystic neoplasms that show central scarring, central calcification, or the circumvascular sign on CT could be diagnosed as serous cystadenomas. And I've showed you each of those, including that draping or circumvascular sign. When either of the first two features is combined with the circumvascular sign, the diagnostic sensitivity could be increased. So again, it's not always going to be easy separating MCNs. Again, difference in age a little bit, but tumor location is about the same. But once you start having things like draping, and when you have more of the septations, I think it's not going to be as difficult a problem as one could suggest, but it is something that you need indeed to think about. The circumvascular sign was defined as the presence of some abnormal arteries surrounding the lesion on arterial phase CT. In addition, tumor size, tumor patterns, and degree of enhancement were also recorded. Central scarring, central calcification, and circumferential sign had high specificities between 97.7 and 100% respectively. However, the sensitivity of central scarring and central calcification was lower. So combining the circumvascular sign with either of the other features increased the sensitivity for the diagnosis of serous cystadenomas to about 83%. So we can be very good at it, but I show cases in conference, and sometimes it's just really hard. Okay, so very, very important. Understand the various signs we're looking for, and think about this when you're looking at cystic pancreatic lesions. Another example, serous cystadenoma pancreatic head. There's some solid enhancing component. You can see multiple small cystic lesions, as well as large cystic lesions, as well as calcification. And when you put all of those together, you really know you're dealing with serous cystadenoma. This is not a look of IPMN, it's not a look of MCN, it's not a look of just a pseudocyst. Another example here, slight prominence of pancreatic duct, cystic lesion in head and uncenate process, multiple cystic lesions. This one, serous cystadenoma, is very good, but if you told me this was an IPMN, remember I showed you some larger IPMNs previously with septations, it would be hard for you to say this is not an IPMN. This lesion will surely require tissue sampling and analysis of the patient's cystic fluid. There are new markers now, this VHL marker, that's very, very sensitive and specific for lesions being serous cystadenomas. Another cystic lesion, tail and body of pancreas, faint calcifications by the tail. It's really almost like a balloon, like a long balloon with very thin septations, calcifications. It measures 10 centimeters or so. This also was a serous cystadenoma. Again, what else could you think about? A big dilated pancreatic duct, it's too big. I guess you can consider an MCN, that's a possibility. A pseudocyst in a patient with chronic pancreatitis because of the calcification, I wouldn't be thinking there. Third pattern, or second pattern, honeycomb pattern, 20%, numerous tiny cysts that mimic a sponge or honeycomb. The tiny cysts may be poorly depicted as individual cysts on CT, and these lesions can appear as soft tissue or mixed attenuation masses depending on the size of the cyst and the amount of enhancing fibrous tissue. One of the things that these honeycomb patterns can do is appear to be solid and very much simulate a neuroendocrine tumor, and I'll show you some examples, and it can be an interesting challenge. Here's a cystic lesion, body of pancreas, obstructing the pancreatic duct. I have to admit, when you look at this lesion, there are calcifications present, but when you see a dilated pancreatic duct and cut off, I got to be thinking about carcinoma. This patient also had weight loss. I can't get around knowing I need to sample this lesion. But then you argue and say the lesion has septations. Could it be a serous cystadenoma? You have the dilated pancreatic duct, which can occur with either. This is one of those you'll need tissue sampling for. The calcification, again, is helpful because we just don't see calcifications in carcinoma. The harder you look on the MIP, the more you see small cysts present. And this was a 4-centimeter serous cystadenoma with that tiny honeycombing type appearance. Or this one, another one, same area, big cystic lesion, or cystic and solid, dilated pancreatic duct, atrophy of the distal gland. Remember, I've said many times when I see glandular atrophy, I'm worrying about cancer. I'm not thinking about a benign lesion. But this is a really good example of a serous cystadenoma that obstructs the pancreatic duct downstream and this distal glandular atrophy. Now, I don't think anyone's just simply going to follow this patient. I think they're simply going to do EUS and look at tissue fluid and then reach the correct diagnosis. But I think as a radiologist, you need to be thinking that this could be a serous cystadenoma. So I'm showing you multiple views, multiple appearances of that lesion, including changing the window width and level, as well as going from different rendering techniques. And again, looking hard on the venous phase. I've mentioned before that the honeycombing, the multiple tiny cysts, are often best seen on the venous phase rather than the arterial phase imaging. So this was a serous cystadenoma, tail of pancreas, okay? Another one, right? Dilated pancreatic duct. Just look at the various images. Serous cystadenoma. Another one. Now we're moving from the lateral portion of the body and tail to the medial portion of the body of the pancreas. Cystic lesion. There is a dilated duct. There is distal glandular atrophy. This was also a serous cystadenoma. You can see it again on the axial and the coronal view. The more you look at the coronal view, remember I mentioned look at venous, the more you look at it, the more cystic it looks, the more the septations and honeycomb pattern comes out to you. And yes, you can get a dilated pancreatic duct and distal atrophy, but here I'm thinking about a serous cystadenoma. You can see it again on the cinematic, nicely showing you the septations and the dilated pancreatic duct. And sagittal view also nicely showing it. Another patient, same type of lesion, moving toward the pancreatic head. Cystic, mildly dilated pancreatic duct, some septations, but could this be an adenocarcinoma? That's how it was sent to us with abdominal pain, but this was also a serous cystadenoma. When you look hard, particularly on the coronal, you see some of the septations, but again, it's not the most obvious case. And with the dilated duct, you have to be worrying, could this be malignancy? But you don't get malignancy with septations in pancreatic adenocarcinoma. You can get necrosis, you can get some thickening and varied enhancement. But this was a serous cystadenoma. There's a little bit of draping of vessels, which can be helpful. Remember, we talked about this draping being present and a good sign of benign disease. Here's a good example, same case, showing you the septations, showing you the cysts, and they're better seen on the venous than the arterial phase. And here it is again, is the venous phase from the cinematic rendering. But again, it's a challenging case. I think this is one, it's hard just to say serous cystadenoma next patient. This patient will surely get EUS with tissue sampling to make sure what the diagnosis is and that you're not missing a resectable pancreatic adenocarcinoma. So just a really, really nice example. And again, here's a few more cinematic rendered images showing you the lesion. The last type, the oligocystic, it's interesting. It does not communicate with the main pancreatic duct. You can get dilated pancreatic duct at times just simply because of mass effect. The thing about oligocystic is they can look like pseudocysts. If you see this patient and you don't have a history, could this be a pancreatic pseudocyst? Yes. There's no wall enhancement. Could it be an IPMN with dysplasia? But I don't see anything with nodular. Could it be an MCN? That's a possibility. Could be a cystic neuroendocrine tumor, but not enough enhancement. This was a serous cystadenoma. Very well defined, sharply marginated against the enhancing head and body of pancreas. Really, really nicely shown. Okay, serous cystadenoma. The lesion, all the world looks benign because there's no nodularity or septations. There's no dilated pancreatic duct. But you know, when you're looking at this in a patient with abdominal pain, how do you know it's not an IPMN? That's why people will sample this lesion with EUS and they will get the right answer. Here it is very nicely as well as we go to negative mode. Here's another one, tail of pancreas, large cystic lesion. Again, you may worry about, is that the tail of the pancreas or it's the kidney? But look at the neck of the pancreas. There's a cystic lesion with calcification. There's calcification as well as some enhancement. Here it is again. You can see it next to the GDA. You can see the lesion by the tail of the pancreas, which is simply, again, you can get fooled at times with cystic lesions. Cystic lesions pushing off the spleen, less common, but off the left kidney or even right kidney, more common. Just a really nice example of coarse calcification, cystic lesion. You don't see much of the lesion. It's mainly calcified, but in the differential diagnosis of calcified lesions, serous cystadenoma, usually it's the larger lesions with central calcification, but not always. Or this patient with weight loss, big cystic lesion left upper quadrant. It could be a duplication cyst of the stomach, could be a splenic cyst, could be a mesenteric cyst, could be something coming off the kidney or adrenal gland. Well, this was an oligocystic serous cystadenoma. Again, it's coming off the gland. I will say lesions that are at the junction of multiple critical organs when they're large and it's near spleen and near kidney and near pancreas and near stomach, sometimes it's not as easy as you might think to make the right diagnosis. But this one's coming off the tail of the pancreas, and this was an oligocystic serous cystadenoma. Okay? Very, very nice example. And another one here. Again, you can see the size will vary. Some of these oligocystics can be 15 to 20 centimeters in size, which can be challenging even for making the diagnosis and even for surgery. But again, there's a range of appearances, and I'm showing you these images to give you a feel. The last thing I'll mention is the solid pattern. There's a solid pattern, and those are hard to distinguish from neuroendocrine tumors. They can look exactly the same. Here's one by the tail of the pancreas, very vascular. Looks like a neuroendocrine tumor. Washes out. You can see the cystic components best on venous phase imaging. That may be the solution in most cases. The arterial phase is pushing you to a neuroendocrine tumor, and the venous phase pushes you to a cystic lesion, which in this case was a serous cystadenoma. Here's another one in the head of the pancreas. Again, could this be a neuroendocrine tumor? The answer is surely yes. Here's some of the septations. On the venous phase, the septations are better shown, and it really much more looks like a serous cystadenoma. So it's a good point to remember that sometimes you will make the best diagnosis. Now, we also know that neuroendocrine tumors like serous solid do wash out with time, so you have to be careful about that. But with neuroendocrine tumors, when they wash out, you're not going to see this cystic type appearance. Another thing with neuroendocrine tumors, often it invades the vessel. With serous cystadenoma, you have that draping of the vessel. So you can see it nicely on the MIP imaging, but the vessel is good. It's simply compressed by the patient's lesion. And again, here it is very nicely shown again and again. So again, solid serous cystadenomas very much can be confused with neuroendocrine tumors. At times as a challenge, you may need to sample them, but things we look at are draping vessels. We look at venous for the multiple septations, which are nicely shown in this case. And again, here it is another example, very similar to the prior case. Arterial phase, complex solid lesion, cystic components, serous cystadenoma, stretching of the vessels. And as you go through the lesion, this one on arterial phase did have the multiple septations present. You can see the size of the lesion on the coronal view. And then you see the stretching of the vessels around the lesion, very nicely shown, again pushing you toward a serous cystadenoma. Again, these cases are challenging. I think most of the time EUS will be done to make certain you have the right diagnosis. But again, the point about dual phase imaging, that with serous cystadenomas, the cystic components are best seen on the venous phase imaging at about 70 or 80 seconds post-injection. Again, very nicely shown on these images. Now, solid serous cystadenoma, it's just amazing how difficult it could be. If I told you this was a neuroendocrine tumor, you would say yes. And in fact, I would say yes. Again, you look at it, looking, the vessels are being stretched. It's a great location for a neuroendocrine tumor. Now it is on the venous. You see some of the septations better. And remember, with these solid lesions or solid appearing lesions simulating neuroendocrine tumors, it's often the venous phase that really allows you to reach the correct diagnosis. And here you can see the same patient with cinematic rendering, right? A really, really nice example of that solid mass, the solid components. And on the venous side, you really see that honeycomb pattern really well. So perhaps we're going to get better using cinematic rendering as a way of differentiating between a neuroendocrine tumor and a solid serous cystadenoma. Beautiful images here showing you the septations. Now, I do want to show this case, and I do want to make the point that this patient was referred in for pancreatic cancer, eventually had biopsy. Biopsy was negative. And after a couple biopsies, we realized we were dealing with not a pancreatic cancer, but with a serous cystadenoma. Very difficult case because it looks solid. Yes, there's a calcification there. That made us think something was not right. When you see a calcification, you got to be thinking it's not pancreatic cancer. Remember, I mentioned before, maybe it's a pancreatic cancer in a patient with chronic pancreatitis, but you never see just one calcification. Here's the lesion again in the uncinate process. Again, it's concerning to me. It's concerning to me as we go to the volume rendered image. And again, on the coronal and volume rendering, it's concerning. When you look at the volume rendering, the cinematic type of volume rendering, the cystic component of the lesion is probably better appreciated. And maybe only on this do you feel comfortable saying that this is a serous cystadenoma, the solid type. Again, nicely shown in the sagittal view as well. But again, it's somewhat challenging. So I do want to make the point that you're not always going to be able to look and say this is the diagnosis. It's just going to be difficult. The same thing in this case, another one, pancreatic cancer. But again, it's cystic. As you go to venous, you see the septations. You see the stretching of vessels. We said this was a serous cystadenoma. Patient had tissue sampling. That was the diagnosis. Again, you also should have thought that perhaps if this was an adenocarcinoma in the head of the pancreas, why isn't there pancreatic and common duct dilatation? You essentially never see common duct dilatation with serous cystadenomas, no matter how they look or how large they are. So that indeed can be a very, very helpful point as well. So again, just showing you, take a look at the images. Again, cinematic, the septations better seen, the cystic components better seen. So again, we are learning better, and that's something we are looking at also as we look at AI. And here's just a few more images that I've managed to show you. So management of diagnosis of serous cystadenoma can be made based on imaging and lab findings. Surgical resection is reserved for symptomatic patients and maybe patients over 4 cm. I don't think that's always going to be the case of 4 or 5 cm being a cutoff. It'll depend on the patient's comorbidities and how we want to manage the patient. Some patients don't want surgery, we'll just simply follow them carefully. But again, to make the point that serous cystadenomas are not always going to be classic. Now, we mentioned one of its great competitors, and something it can look just like, is a mucinous cystic neoplasm, or MCN, and that's going to be the subject of our next lecture. See you soon. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.